afternoon. Thank you for attending this month's OCHIN Grand Rounds. I am your host, William Pinnock, and today I could not be more excited to have Dr. Jonathan Winickoff of Harvard Medical School and Massachusetts General Hospital as he presents on prevention and treatment of tobacco use in families. Dr. Jonathan Winickoff is a practicing pediatrician at Massachusetts General Hospital and professor of pediatrics at Harvard Medical School. He has training and experience in health services research, medical ethics, neurobiology, statistics, and behavioral theory. Dr. Winickoff's research focuses on strategies to address tobacco use and exposure in families. His research has led to the creation of the clinical effort against secondhand smoke exposure, also known as the ECS Program, now available in all 50 states. In addition to over 100 peer-reviewed original research publications on tobacco, he has drafted key tobacco control policy and served as a scientific advisor for the CDC Communities Putting Prevention to Work, the Massachusetts Tobacco Control Program, Head Start, WIC, the Food and Drug Administration, Department of Housing and Urban Development, the National Academy of Medicine, and the U.S. Surgeon General through the Interagency Committee on Smoking and Health. This session is being recorded. Attendees are muted upon entry, but if you are not, please mute your microphone and pose your questions through the chat box. This presentation will last approximately 45 minutes with 15 minutes at the end to answer any questions you may have. We will now pass the mic to Dr. Jonathan Winickoff for Juuling and Smoking, Prevention and Treatment of Tobacco Use in Families. Dr. Winickoff, the floor is yours.
Thank you so much, William. I am thrilled to be here speaking to the OCHIN audience. And I wanted to give a special shout out to those of you working in community health centers. We've had a really hard year, haven't we? And I think that we have to acknowledge that. And now I hope that you're able to see a little bit of the light on the horizon as I do, as we get those vaccinations rates up. So let's take a look. I'm going to share my screen and get into our presentation. And let's see if we got it. All right. Are you guys seeing my presentation? Super. Okay, so we're going to talk about strategies to reduce vaping and smoking. We're also going to talk about this as a family level issue. Today, we're going to learn about the need to address family tobacco product use in the pediatric primary care setting. Although these lessons are also going to be relevant for any family practice community health settings as well. We're going to learn best practice solutions for primary care healthcare settings to screen and treat tobacco product use using EPIC. And we're going to explore opportunities together to make health system level changes that will increase screening and treatment for tobacco product use in families. So just a little bit of background about tobacco. It's the leading cause of preventable disease and death in the United States. Smoking harms nearly every organ of the body and affects a person's overall health. And we're talking about over 480,000 deaths every year. 1 in 5 deaths in the United States is directly attributable to tobacco use. That includes 1 in 3 cancer deaths. So a lot of the efforts these days on screening and prevention of cancer, we may talk about prevention of cervical cancer, we may talk about breast cancer, we may talk about lung cancer. But 1 in 3 of them are going to be attributable to tobacco use. So if we're not doing a good job with tobacco, we're not doing a good job with overall reduction of morbidity and mortality in the United States. Additionally, adult smokers die about 10 years earlier than non-smokers. Approximately 14% of the US adult population smokes. That's probably a little bit higher in community health centers. And that's 34 million people over the age of 18 are current smokers. In addition, 58 million non-smokers are exposed to secondhand smoke, including 40% of children aged 3 to 11, and this amounts to about 300 billion in healthcare costs annually. And we have to acknowledge COVID-19. We're going to take a look at how many deaths in 2020. There were 383,000 deaths in 2020, 178,000 deaths so far in 2021. But just to put that in context, that's less than there are dying every year, each and every year of tobacco use. Teens and young adults who use tobacco products, particularly vaping, are 5 times more likely to contract coronavirus. And following the contraction of coronavirus, individuals with a history of smoking are over 9 times as likely to develop severe illness as those with no smoking history. So now I'm going to show you about the new look of nicotine addiction in the US. This is what a lot of kids are using. It's vape systems. Some are meant to deceive. You have a Coke can down there. You have some dabbing going on. You have a vape system here that looks like an inhaler. And the ways that people vape, there are just many, many different systems. However, one has really come to the fore recently, and that is the Juul device. So on the left-hand side, you see a Juul device with 4 pods next to it. There's 1 pod loaded into the device. A single Juul pod equals an entire pack of cigarettes. So at a party, a kid can basically Juul an entire pod and have the equivalent of a whole pack of cigarettes. And basically the company Juul, which is now owned also by Altria or Philip Morris, they developed a new biochemistry to the nicotine to have a super high concentration of nicotine, but it didn't have any aversive response as you inhale it. So you're just able to vape puff after puff and get the entire pod used without any adverse effects in your throat. And so that's part of why it's the biochemistry, not just the marketing, that brought a lot of kids into the addiction world of tobacco. When I give talks to high schools, I can't even show these images because they're so compelling. Kids wouldn't even listen to the rest of the talk. They see this group of girls and they want to be part of it, or they see that guy, there he is with, getting attention from other teenagers. He has a Juul, they're giving him attention. He's the cool guy, they're the cool girls. So I can't really show this because people are like, yeah, all that other health stuff, I don't really care. I just want to be those kids. I want a sense of belonging. I want to be using that Juul device. Recently, in the last year, we've seen a surge in disposable e-cigarette use. So these are the next thing that have come up as the FDA has tried to crack down on the flavored Juuls. Those are still present, kids still using those. But now we have these disposable. They look just like Juul, and they come in flavors. And the FDA did not ban the flavored disposables. And here you see the surge from 2019 to 2020. So we have a shifting landscape, and we have to address it as clinicians. It's sort of dropped in our lap. How do we do that? First, I'm going to show you that this is really a young adult problem. You can see the biggest use is in the 18 to 24-year-olds. Overall, we have 15% of adults using electronic cigarettes, slightly more men than women, but it does drop off over the years, over the age groups. And what I would say here is that a lot of these kids, a lot of these young adults, 18 to 24, were never going to be tobacco users. They were going to escape. They were going to not be using tobacco. And here they are at very high rates of electronic cigarette use. So what are the ingredients found in e-cigarette solutions or e-juice? I'm just going to list them here. Humectant, that's propylene glycol, not safe to inhale. Flavorings, all of these flavorings can create inflammatory states in your lungs, not good. Nicotine, which can be present even when the concentration in the vape device is listed as 0 milligrams per milliliter. Toxicants, carcinogens, cytotoxic metallic nanoparticles, silicates, and other psychoactive ingredients added by users. A lot of people will add in marijuana into a nicotine product, thereby kind of spliffing their product and getting both the THC and the nicotine. Interestingly, the nicotine is more likely to create the long-term addiction. Marijuana also can cause long-term addiction, but the two really create a vaping culture that's mutually reinforcing. In terms of e-cigarettes and health effects, and some of the slides are busy, I wanted to get the information here because I know this is being recorded, so I want you all to have the information, but you don't need to worry about taking notes because this will be available. Chemicals in e-cigarette aerosols, the formaldehyde, the acrolein can cause DNA damage and mutagenesis. There's biologic plausibility that long-term exposure can cause cancer and adversely affect reproductive health. Why do we not know yet? Because its products just simply haven't been on the market long enough. Nicotine exposure during adolescence can cause addiction, structurally alter the developing brain, and cause mood disorders and attention problems. And there's a 75% higher chance of chronic bronchitis, emphysema, chronic obstructive pulmonary disease in current e-cigarette users compared with never users. Now, here's the landscape for adolescents and adults. They could smoke tobacco, traditional tobacco. They could vape, or they could use both. And so we as clinicians have to take account of this and be able to handle all comers into our clinical settings. So let me tell you a little bit about dual use. From our latest CEASE trial, we had 11% of parents who smoked cigarettes who also reported using e-cigarettes. The characteristic of these users, they were more likely to have a young child, so younger people, think younger child, more likely to plan to quit smoking in the next 6 months, so they were more engaged with the quitting process, more likely to have recently tried quitting smoking in the last 3 months, and the majority had smoke-free home policies, yet fewer had vape-free home policies. So a lot of people are thinking, oh, vapes, totally safe. Let me smoke, let me vape around the kids. Oh, I'll smoke outside, but I'll vape right next to my kid or in the car because those are totally safe. Not true. We need to dispel those myths. All right, so there's 3 ways that I think about how this aerosol comes into you and how this smoke comes into you. First-hand smoking is when you inhale the smoke or aerosol directly into your lungs. Secondhand is where you exhale it or it's released from the end of the burning cigarette. And then third-hand smoke or third-hand aerosol is that contamination that remains on surfaces and in dust is re-emitted into the air, reacts with oxidants and other compounds to yield secondary pollutants. So this is a big issue for kids. And let me take a look and show you here. We have a living room and a car. We have the cloud of secondhand smoke and aerosol coming in. It's so ominous. It comes in and then it coats all these surfaces and it gets re-released over time. The nicotine comes out and it combines with nitrous acid and ozone to create tobacco-specific nitrosamines. These are class 1A carcinogens, some of the most toxic compounds known. And we're basically polluting those environments where kids work, sleep, play. So there's no risk-free level of exposure to tobacco smoke or third-hand smoke. There's just no safe level. That's what the Surgeon General has said. And even at tiny levels of exposure, Yolton, using the NHANES data, demonstrated a significant inverse relationship between a biomarker of tobacco smoke, cotinine, and block design, reading, and math scores. So this is affecting the developing brain. And the state of science really supports completely smoke-free environments for all children, even at times when the children are not present. So think about a family daycare. The kids go home, but then people are smoking in that daycare. Think about times kids go to school, but then the parents smoke inside. Those spaces are contaminated, and we need to address that. Here's just look at that wall. You know, those white spots on the walls, I bet you can think about what those were, right? Those were pictures that created a white spot because the tobacco smoke and the nicotine couldn't get back there. But look at that. This is actually from an apartment of a woman who died of lung cancer. But children who live in these homes with third-hand smoke have detectable levels of exposure in their bodies, like not surprising. The concentrations are disproportionately higher than adults because kids interact with surfaces in a more close way. They breathe closer to surfaces. They are like little human mops. They sort of pick up all of the dust and then they lick their hands or their teething. And they're so small. So they might pick up twice the amount of house dust as an adult, but they're only 1/10 the size. giving them a 20-fold increased dose of third-hand smoke compared to adults. And that's concerning to pediatricians and to family practitioners who care for kids, nurses, and other clinicians. These contain carcinogens that put kids at risk of cancer, and third-hand smoke is detected even within medical settings in the bodies of medically vulnerable children. So we found that third-hand smoke belief is associated with strictly enforced smoke-free home and car policies. So counseling about this as a real thing, as a contamination of space, helps with setting smoke-free policies. And patients and parents who believe that it's harmful are more likely to feel that, are more likely to believe that being a smoker gets in the way of being a good parent, and are more likely to use assistance to help them quit. So there's actually this role conflict between parenting and smoking, and those two things really get in the way of each other. And where people have that dissonance, they're more likely to engage in treatment. And parents who change their third-hand smoke beliefs in favor of harm are more likely to make a quit attempt. So this brings me to the cessation imperative. When we're talking about families, the only way to protect non-smoking family members completely is for all family members to quit completely. And all families who use any tobacco product should receive assistance to quit in the primary care healthcare setting. So now we're going to talk about that, what that looks like, and why it's just so important that we figure out how to do this, and we figure out how to do it in a way that doesn't derail your day. So that's going to be the next part of this talk. So family cessation is the goal. This will eliminate the #1 cause of preventable morbidity and mortality, eliminate second and third-hand smoke exposure of all household members. So you get, let's say there's one parent who smokes, but there's 5 kids in the family. You've just protected 5 kids when you get that parent to quit. You decrease the economic impact of smoking on families. So the average pack-a-day parent spends over $2,000 a year on their smoking. So I think we all know the effect of poverty on health. Smoking is a component that worsens the cycle of poverty for families. And in terms of teens, we want to protect the kids from ever growing up to be a smoker. When we get a parent to quit smoking early, we decrease the chances that that teen will ever grow up to be a tobacco user by 2 to 4-fold. And then we eliminate smoking in future pregnancies. And that turns out to be a big driver of savings, healthcare savings, because we eliminate a high risk of low birth weight and premature babies. And those babies often are the ones who are in NICUs, 24-weekers, and end up with bronchopulmonary dysplasia for their lives. So what is this opportunity? Maybe you think, no, parents aren't really interested in quitting. Well, it turns out we studied this and we found the majority of parents would accept medications to help them quit, but less than 1% get it. The majority of parents want to be enrolled in a telephone quit line, but only 1% get enrolled. I think it's because these are young, healthy people. They're busy and they just don't have access to care. But the majority of parents would be more satisfied with the visit if the child's doctor addressed their smoking. And many parents see their child's healthcare provider more often than their own. So, someone's very busy, maybe they're not taking care of themselves. They care about their kids, though. They're going to get them vaccinated. And there's 10 visits in the first 2 years of life just for required visits. So that's a lot of opportunity that we're leaving on the table, particularly for parents who may want to quit and just haven't had a chance or have access to these treatments. So tobacco dependence, here are the principles. It's a chronic relapsing condition. Nicotine is addictive. Effective treatments exist. And every person who uses tobacco should be offered treatment. So there's 3 easy steps to offering treatment. And I'm going to talk about what the steps are. And it's great if you can do this as part of your clinical visit, but I'm a clinician and oftentimes it's hard for me to do anything other than just get through the day. So adding on anything else seems hard, but I'm going to go through the 3 steps. And then at the end of the talk, I'm going to show a way that we might adapt Epic to have some of this be automated for us and happen even before we even see the families. So step 1 is the ask, step 2 is assist, and step 3 is connect. Ask, assist, connect. So every year we want to ask families about tobacco use in at least 2 ways. Who in your family uses tobacco products like cigarettes and cigars? And who in your family uses e-cigarettes or vaping products? If the answers are nobody, then we can take that off the table and go till the next year and ask them again. With the ask, we ask if you find someone, then are you interested in quitting? Would you like a medication to help you quit? Would you like free help from the telephone quit line or texting program? And I will say that anyone can sign up anyone to the free text to quit program in the country. So it's free, except there are rates for texting. So some people who are in poverty will not like the idea that, oh, they're going to be charged for text messages. So you have to make sure that people are okay, or maybe their plan allows for some texting, so that it's possible that they still will get charged. But I can just tell you quickly how to do that. So take out your phone. This is during the grand rounds. You actually can take out your phone. This is like probably the first time this has ever been asked of the audience. But take out your phone and go into text message settings. And if you learn nothing else from this talk, at least you'll be able to sign someone up for smoke-free text. So what you do is you create a new text message, and then you text 4. This is the 2. Do 2 in the 2 category. You say 47848. So do it right now. 47848. And then in the text message, do 7848. So 7848. So go ahead into the 2 part, do 47848, and in the text message part, 7848, and see what happens. I'm testing it now. And I want in the chat, if you can just say whether anyone is able to connect, that would be great, just to let me know, like, yeah, it worked, or not working. Get anyone? Did anyone do it yet? Let's see. Oh, looks like someone chimed in. All right. Anyway, that's what we do. We basically can sign people up. And you can do that. It took us about a minute. It can take about 30 seconds when you get good at it, just to get someone else connected into a free program. You might not have time to counsel them, but guess what? Smoke-free text does have time to counsel them. And in smoke-free text, there's a hot link to the quit line in that person's state. So again, if you don't nothing else, learn nothing else, that this is key. And in fact, the 47848, that actually comes out to spell I quit. And in the text message, it spells out quit, if you have the letters, that correspond to the numbers. Okay, so let's move on into assist. Set a quit date in the next 30 days, recommend medication for assisting quitting, and recommend the quit line and the smoke-free text message. Now, the free quit line is free. And again, you'll have time to do that. You might not have time to be a tobacco control counselor during your visit, but you can connect them to free care. All right, and then make sure that they set a smoke-free and vape-free home policy if possible. And this is the connect part. This is what we already did. Connect them to the quit line, smoke-free text, and arrange some follow-up. And then document it in the electronic medical record. So we studied an automated system to do this. We tested to test whether pediatric offices can implement an electronic tobacco user identification system that facilitates delivery of tobacco cessation assistance to parents. This was to test the effectiveness of the intervention on parental smoking cessation over 2 years. We did this in 5 different states, a control practice and an intervention practice in 5 states. And intervention practices were trained to implement the program and to basically allow people to do the pre-visit screener at every visit. Control practices did not receive any training. So we used iPads, which could also be done as a pre-visit screener in MyChart in Epic. But what we arranged was a proactive referral to the quit line if they wanted it, engagement in the smoke-free text program if they wanted it, and nicotine replacement therapy if they wanted it. And then we followed up regarding their tobacco cessation using a disease registry. So this is a big slide, but I wanted to show you all the data here in terms of the process. So in terms of handing out iPads and getting these pre-visit screeners done, we did that in 5 different practices across the top row here. So you're going to be focusing on the red figures here, but basically every practice was able to do this. And that happened 50,000 times during the study. So you're doing it, you're screening, and then hopefully it's getting into the electronic health record so the clinician doesn't have to do it. Identifying tobacco users after visit. So 2,764 times we identified a person who was doing the survey as the tobacco user. And then smokers requested a prescription. 56% of them wanted nicotine replacement medicine. So that's key because we didn't know about those people before. And now suddenly we're getting them help for quitting. And then in terms of enrollment in the quit line, 41% wanted enrollment in the quit line. So these are people, again, who are engaged, they want access, and we just weren't picking them up before. So did this study work in terms, not just process, but did it help people quit? What we found was over a 2-year period in the intervention practices compared to usual care control, we saw a 3.7% decline in the overall parental smoking prevalence. So each year we had a little bit less than 2% decline in the smoking prevalence in the population. Now, let's say we had a 14% smoking smoking rate, then it would take about 7 years of running this program to get down to the low single digits. And that's a lot faster than what we see as the slope of the curve right now. So just simply asking this year after year can make a big difference in getting those people, those families, to be completely tobacco free. And then we saw a 5.5% increase in cotinine confirmed quit rate. So this isn't just people saying that they quit, but it's actually people who quit themselves. Okay. So what was the cost of this program, running it per quit? It was $1,132, so $1,132, and this was the change in parent-reported smoking prevalence in the 2 groups. So when you look at getting 10 years of extra life, when you look at the multiplier effect of getting kids smoke-free, the decreased chances that they grew up to be smokers, this turns out to be a very good investment in money that people could do in order to help their population level health. So there were some barriers, though. What we learned was that sustaining it was hard. There was a lack of system level integration. There was lack of method to facilitate connection to external resources. And the tobacco control intervention wasn't fully integrated into the electronic health system. So what did we do? We went back to the drawing board and we developed a different program, and that was the ECS program. And this one is designed to be disseminable. It's innovative. It's electronic health record based approach. It supports the workflows in the pediatric setting. So in a pre-visit screener, direct to parents and patients and caregivers, people indicate whether or not they use tobacco, they identify their quitting preferences, and then the EPIC-based questionnaire is done and fills in the problem list in my chart and on the patient's medical record. The electronic health record does the prompting of the clinician to deliver the motivational message. And as part of the questionnaire, and I think this is the most innovative part, before the patient even sees the doctor, they've already gotten directly connected to the quit line, if they wish, the smoke-free text, and they've also gotten a nicotine replacement therapy prescription mailed to their home. So I think this is key because it takes a lot of the guesswork out of whether the clinician is going to have time to do the intervention, and it just simply happens. That's the default. In order to not have these things happen, the parent actually clicks them off. So the default is, let's help everybody quit smoking. And if you don't want something, unclick it. All right, so then and it also documents what it does in the electronic health record. All right, so what does this look like in practice? I hope this is familiar to some of you. This screen is just an epic screenshot. So this is what the clinician will see in the case where the parent accepts treatment. And what you see is just above vaccines, you'll see that they accepted nicotine replacement therapy, they accepted free quit line, they did not want smoke-free text, and then you click the green check, and that shows that you discussed it with a parent. The tool sort of takes care of the billing and documenting in your note about what you talked about, and then you can go on to the rest of your clinical visit. Now, in the case where the parent does not accept treatment, you can still have the option of discussing it with the parent, and maybe you're able to get nicotine replacement accepted, maybe you're able to get them to the quit line, and maybe you're able to get them to smoke-free text. But really, it's as simple as checking the box, and then you have the direct connection happening. And then again, it bills and documents in the note and in the problem list what happened. So in terms of future directions, it would be great to have a comprehensive ECS project that maximizes the social network of the child to help all connections to that child quit tobacco use. And we think doing an ECS dissemination implementation grant in the clinical setting, especially in community health centers, would be a really powerful study to do. And we think it would help drive down smoking and tobacco use in the country. So in summary, the outpatient setting should be used to deliver tobacco dependence treatment to all patients and household members. Parents and families should be the #1 priority population for tobacco control efforts. And I'll stop there. And I hope that I've left time for questions. I wasn't keeping track of time, but please do communicate with us. Feel free to use these slides. And I hope that we get a chance to work together to build this system in your health centers and to make sure that we do a good job with this issue in your patient population. Thank you so much.
Thank you very much, Dr. Winickoff. And I want to also give a special thank you to the Bridge C2 Center out of Oregon Health and Science University for connecting us with Dr. Winickoff. And thank you to everyone who attended today's session. Be sure to follow Harvard Medical School on Twitter at HarvardMed. Follow CEASE at CEASE Tobacco. That's CEASE Tobacco. Follow Massachusetts General Hospital for Children at MGHFC, and follow OCHIN on Twitter at OCHIN Inc. and over on LinkedIn. In addition, be sure to head over to ochin.org and advancecollaborative.org to read the latest on our research studies, blog posts, and upcoming events. And OCHIN Grand Rounds will return on June 11th for its Season 5 finale with Dr. John Munch of OCHIN and Oregon Health and Science University, Megan Hoops of OCHIN, and Dr. Clarissa Sue of Kaiser Permanente Washington Health Research Institute as they present on evaluating the impact of Medicaid treatment reimbursement changes on opioid prescribing and patient outcomes among patients with low back pain. So from all of us at OCHIN and Dr. Winickoff to all of you, have a great weekend and stay healthy out there.